Recording. Yeah,
Okay.
so recording started.
Oh, okay.
All right, so.
Okay, good morning, everyone. Today, myself, and Perla, we're going to present myocardial infarction, which is known as heart attack. Okay, so talking about epidemiology, according to heart.org and Netscape, it is approximately 1.5 million cases of myocardial infarction annually here in the United States. The incidence rate is approximately 600 cases per 100,000 people. The rates attributable to acute MI since the mid-1970s has been related to this condition according to the data in the United States, and it has not declined yet. The death rate related to acute MI is approximately 3 times higher in men than in women, and is more frequent in African American patients and compared to those with Caucasian race. We have some risk factors in here too. They are divided in things that cannot be controlled and things that can be controlled. So the things that can be controlled is age, which is men from 45 and above, and women after 55 years or after menopause. Family history as well has something to do, like it increases the chances of inheriting of having cardiac diseases when a father or a brother were diagnosed with heart disease before 55 years of age, and if a mother or a sister was diagnosed with heart disease before 65 years of age. Also, we found preeclampsia, that it also has something to do with the risk as a risk factor. This is related to pregnancy, and this is characterized by the high rise in blood pressure and excess protein in urine. It is linked with the increased lifetime of risk of heart disease, including CHD, heart attack, and heart failure. There is also being an ongoing research with COVID-19. One of the long terms that it can lead to is to myocardial infarction, and I have also a video to support it. I'm gonna present it. Let me know if you guys can hear it. I'm sorry, do you guys cannot hear it?
Is there a sound associated with that?
Yes.
No, I can't hear. No, I can't hear anything.
I don't know how to. I don't know how to adjust it. Let me check.
Yeah, it's okay. You can, is this a, if that's a video that you can post in Blackboard, we can just um, post it separate. Just send it, send me the video and I'll post it in Blackboard for the student.
Okay,
Yeah,
okay, thank
yeah,
you.
yeah.
Mm, okay, so just give it. Okay, all right. Okay, so the things that can be controlled is smoking, which is the cigarette smoking is a powerful independent risk factor for sudden cardiac death, and even exposure to smoking also increases the risk for heart disease and in non-smoker individuals. Um, High blood pressure also increases the workload, causing the heart muscle to thicken and become stiffer. This is not normal, and this cause can increase the chances of stroke, myocardial infarction, kidney failure, and congestive heart failure. We also have high blood cholesterol. Oh, sorry, high blood cholesterol. This is including the diets that have saturated fats, trans fats, like I said, the cholesterol, triglycerides. Um, that includes in unhealthy diets. Also, overweight and obesity are also a risk factor for this. Um, they also have the lack of physical inactivity. Um, it is at least recommended to do some sort of activity at least for 30 minutes every day to decrease the chances of having a cardiovascular disease. And we have high blood sugar um, due to insulin resistance or diabetes. And we have also metabolic syndrome, which is the combination of obesity, high blood pressure, and high blood sugar that tend to occur together. In general, the person who has metabolic syndrome is twice as likely to develop a heart disease and 5 times as likely to develop diabetes as someone who doesn't have metabolic syndrome. And that's all for risk factors. And we have the etiology, which is caused by atherosclerosis, which is they're responsible for mostly coronary syndrome cases. Approximately 90% of myocardial infarctions results from acute thrombus and obstructs an atherosclerotic coronary artery. Um, this is built up plaque in the coronary artery, like as much as we know from this class, and it can also be the erosion can also be uh, also considered to be a major trigger for the coronary thrombosis. It can also result from hypoxia due to carbon monoxide poisoning or acute pulmonary disorders. And there are other etiologies such as oxygenation, myocardial ischemia, including coronary artery embolism, which accounts for 2.9% of patients. Also, cocaine-induced ischemia, coronary dissection, and coronary vasospasm.
Okay, so I'm going to be talking about the pathophysiology. So an MI occurs when the flow of blood to the heart is blocked. The blockage is often a buildup of fat, cholesterol, and other substances that form a plaque in the arteries that feed the heart, the coronary arteries. And sometimes a plaque can rupture and form a clot that blocks the blood flow. And then the interrupted blood flow can damage or destroy part of the heart muscle. And that's a picture that shows it. You can go to the next slide, Tiffany. Okay, signs and symptoms. Myocardial infarctions can produce clinical symptoms that include extreme chest pain that may radiate to the neck, jaw, or arms, called referred pain, a sense of substernal heaviness, squeezing or pressure, shortness of breath, dyspnea, hypotension, or hypertension, And recent clinical findings indicate that symptoms may vary between men and women. For instance, chest pain is less common in women. Instead, they experience more weakness and fatigue and dyspnea instead.
And those are our sources as well. And we are done for today.
Is that the link for the video, the last one?
Yes, that's the video.
Yeah, then I believe I'm not sure if the recorded lecture will allow them to, to access the video. But anyways, you can just send me the link and I'll post it.
Okay.
Yeah.
I will. Thank you.
You're welcome. All right, excellent, very good. Any question for the group? Any questions for Perla or Tiffany? Okay, so we'll continue the content on cardiovascular and lymphatic system, and the yesterday and same thing for Tuesday that we left. We stopped at the aneurysm. So one more time, any questions from the previous content? We are going to spend 3 sessions on cardiovascular system. That's the longest, system. Make sure that we cover everything and we, spend, sufficient time on each subject or disease, given the significance and the comprehensiveness of the system and the number of diseases that we have to cover as well. So the aneurysm, one of the questions raised on Tuesday about the risk factors for aneurysms. So first of all, the aneurysms can be true aneurysm or false aneurysm. So the false aneurysms, which is what is called pseudo-aneurysm or false aneurysm, which is not a true one. It's a disruption of the arterial wall of the blood vessel with bleeding that is contained by surrounding anatomic structures. There is bleeding and there is disruption of the wall, and it will show on diagnostic, studies as if it's like an aneurysm, but it's not a true aneurysm. It's a false aneurysm. So the false aneurysm, the false ones, can result from trauma, from infection, from the graft surgery, like the patient has a PAD, peripheral arterial disease, and they undergo a graft surgery for that PAD, and that could result in a false aneurysm. And there is all other causes for the false one. Now, the true aneurysm, we said it involves all the 3 layers of the artery becomes very weak. So that's why part or one segment or section of the artery will be, out pouch or bulging or protruded due to that weakness. And it's it becomes like thin layer, and it's very, dangerous that, this aneurysm could rupture. So the major risk factor, the major complication from the aneurysm is the rupture of the aneurysm. The aneurysm can affect the large arteries like aorta. It also can affect the ventricles or the heart, especially the left ventricular. We call it LV aneurysm, left ventricular aneurysm. So the left ventricular aneurysm affects the left ventricle. So this is the aortic one. So this is the angiogram showing the fusiform abdominal aortic aneurysm. That's why we call it AAA, abdominal aortic aneurysm, AAA. It's known, among the medical professionals as AAA, which is abdominal aortic aneurysm. And that's the most dangerous one because that's, it affects the largest, blood vessel, and it's, it's an artery, largest, artery in our body, and the danger of, the rupture of this aneurysm in the aorta that results in a severe internal bleeding. This is just for information. I mean, like, I included these figures or pictures just, to show you the some of the surgical modalities and surgical treatments for aneurysm. Some of them is minimally invasive. Others would be like, major surgery that, we, requires the vascular surgeon to, reconstruct and to, to fix the, the aneurysm. Other, procedures would be minimally invasive, which is, just through the small incision in the groin with the catheter in advanced in the femoral artery. So the aneurysm, I have a case. Yes. Okay. Well, it's supposed to have a case study here, but if we say that the 70-year-old man with hypertension presents for a routine appointment, and the patient quit smoking 20 years ago, but the history shows that the patient had used to smoke 20 pack a year. So that's, we do some calculations. We came out, we came up to a number which is 20 pack / year history, which means, patient used to heavy smoker. Now, the screening for, so this is the point here about this, about the scenario. The patient who was 70 years old with hypertension and then had a history of smoking. The United States Preventive Services Task Force, they have guidelines. Their guideline says all individuals between 65 and 75, whoever smoked at any time in their life, even if they used to smoke and quit smoking, or currently smokers, they have to be screened for aneurysm, because the aneurysm it doesn't result in symptoms, especially before it ruptures. When there is an aneurysm, most of the time patient they are asymptomatic. There are no symptoms. So the screening for this one would be, the highest risk factor would be age, hypertension, atherosclerosis. So that's why we have to screen it in that age group, 65 to 75 years old, who ever smoked. The cardiac aneurysm, which we said that can be and the most common type of that is the left ventricular aneurysm, which most of the time results when there is an acute infarction, when infarcted heart wall is thin, and then it will kind of bulging like this during the contraction, like during the systole or contraction, the part of the ventricle will be bulging or protruded, outpouching, that kind of aneurysm that affects the ventricles, especially the left ventricle. So these are just briefly the different types of aneurysms. The most common one and the most serious one is the aortic aneurysm, the abdominal aortic aneurysm. It's especially with the AAA here that patients are often asymptomatic, and most of the time we discover this during the routine physical examination or evaluation for unrelated problems, we will find that this patient has an aneurysm. So the aortic aneurysm is most often associated with atherosclerosis, thrombus formation. So before we get to the thrombus formation, what would you anticipate from, let's say that you are assessing the patient for unrelated, diseases. Patient is 70 years old. You are doing physical assessment, and what would you anticipate to find out in terms of physical? You're doing physical exam, and what are some of the findings that are consistent with the aneurysm? If you go back to the physical assessment course, given there is a large blood vessel like the aorta, the abdomen, and there is an aneurysm, which means there is a turbulence of blood is going to, let's say 1 or 2 centimeters of aneurysm, and which means there is a turbulence of blood in that area. As you assess the patient, what would you anticipate to find out?
In the lower extremities can be edema.
From the aortic aneurysm?
What about hypertension from it or pain? I
The
know.
patient is, most of the time they are, they have hypertension. That's one of the risk factors for the aneurysm. But two things. The turbulence of blood will, let's just focus on one finding, which is called the arterial bruit. Bruit is consistent with the turbulence of blood and the aneurysm. So the turbulent blood flow will sound in the artery, in that specific segment of the aorta, which is due to the aneurysm. That is going to be the finding consistent with the arterial obstruction or aneurysm. So if there is an arterial obstruction or aneurysm, you'll find the turbulence of blood in that area, which is consistent with what's called the arterial bruit. Arterial bruit. So bruit always, will be a finding in the blood vessel when there is an obstruction or aneurysm. Bruit. Same thing. In adult health 2 or 3, and in clinical study, I'm sure you went over, maybe already have seen cases like patients with on hemodialysis with kidney failure, right? End-stage disease, and they have an AV fistula. Anyone ever had a patient with AV fistula in the forearm or upper arm? Arterial venous fistula, which is an access device for the hemodialysis.
Yes.
Right.
Yes.
So this fistula, if you listen with your stethoscope and put the bell on the fistula, you will hear that bruit. So that's from the turbulence of blood in the area. Same concept. And the throat, you can feel the vibration on that bruit on the fistula. You can just put your fingers. You can feel that kind of vibration in the area due to that same thing, the turbulence of blood. So for AV fistula, you will assess the patency of the fistula by assessing the thrill, palpation, and bruit with auscultation. So just the concept here is that the bruit, the arterial bruit, will be consistent with as a finding, is consistent with the arterial obstruction or aneurysm. So patients with that, with the abdominal aneurysm, we anticipate that there will be a bruit. All right. So All right, so thrombus formation, we went over the thromboses in the previous lecture or session, and we said that the thromboses or blood clot would form according to the Virchow triad um, in response to three major factors: endothelial damage, or hypercoagulation, or what's the third one? Either there's hypercoagulability, there is high rate of blood clot formation, or there is the endothelial damage to the endothelium of the blood vessel, or if the blood is stagnant, blood pooling, right? Stasis of the blood, like patients with varicose veins, right? So the thrombus formation here, it's the blood clot in the blood vessels, in addition to, with the focus here is on the myocardium, but it's both myocardium and the arteries. And the arteries here will focus on the coronary arteries, but it can also affect any artery in the body, right? So the risk factors here, we said here internal, irradiation, or the edges, or the due to surgical procedures, the blood vessels, there is some roughness, or it's not smooth enough. So that's why the blood clot will easier form on the rough edges or membrane. If there is an inflammation or traumatic injury or infection, or even blood pressure is low, because the low blood pressure will lower the flow of blood, so become more stagnant and stay, blood stasis. But the embolism would be defined as any bolus of matter that is circulating the bloodstream. It can be a blood clot that has been dislodged from, let's say, lower extremity, and traveling to the, travel to the lungs, or to the heart, or go into the brain, and that will become an embolus. So what's the danger of the embolism? Let's say patient developed a DVT, and then the blood clot dislodged from the lower extremity in the DVT from lower extremity, and then travels to the heart, for example.
Well, then there would be tons of fluid around the heart, so that could be an issue.
There will be an obstruction of the blood vessels, and that results in ischemia or infarction. Ischemia, so it's the blood clot's going to occlude the artery which perfuses the heart. So that's coronary artery is being obstructed. So the obstruction of the coronary artery, which perfuses the heart, result in ischemia, or if that's complete occlusion, that will be infarction. So the tissues that are distant to the occlusion will be deprived of oxygen and nutrients. And this table lists all different types of emboli. You will go over these different types of emboli. For example, there is amniotic fluid embolism. There is also what is called the fat embolism. And who would be affected by the fat embolism, or at risk to develop the fat embolism? And the patient will, the clinical picture of patients with fat embolism will be very close to a patient, or very similar to a patient with acute respiratory distress syndrome, acute ARDS, acute respiratory distress syndrome. Fat embolism will result from fractures patients who sustain fractures, especially of long bones, like humerus, femur, radius, ulna, fibula. These are long bones. And patients who sustain these fractures may develop a fat embolism as a complication. So the myocardium, or this one is, it's about the embolism. The embolism, if it travels to the brain, will cause the embolic stroke. If the blood clot travels to the heart, it will cause ischemia like angina or acute myocardial infarction. If it travels to the lungs, it will result in pulmonary embolism. PVD, which is peripheral vascular disease, we have different forms of this disease. The first type is called Berger's disease or thromboangiitis obliterans, and it affects small to medium-sized arteries and mostly upper and lower extremities. The disease is believed that it will result in thrombi, which is blood clots, small, and result in vasospasm. The patient will have, experience pain, tenderness, and hair loss in the affected area. And that's because that's due to the decreased perfusion. And the symptoms are caused by the slow and sluggish blood flow. And can lead also, as I see here in these pictures, can lead to the, what do you call this? What would you call this? How would you describe it?
Necrosis.
Necrosis or gangrene. So it can lead to necrotic or gangrenous lesions. The other type of the PVD, peripheral vascular disease, is called Raynaud phenomena or Raynaud's disease. And also it affects arteries and arterioles of the fingers. It also may affect the toes, but it's very, less commonly affecting the lower extremities or especially the toes. It's morely the fingers. And the pathophysiology includes something like an imbalance in endothelial derived vasodilators like because the nitrous oxide or the nitric oxide, it's a vasodilator. So there is an imbalance between the endothelial derived vasodilator like nitrous oxide and the vasoconstrictor like endothelium or endothelin 1. The endothelin 1 is a vasoconstrictor, and the nitric oxide is vasodilator. So we have more of the endothelin 1 than the nitric oxide. That's what they found in those people with this Raynaud's disease, that they have more of the endothelin because that's vasoconstrictor more than the nitric oxide. So when you hear nitric oxide, it's a good thing. It's a vasodilator. But the endothelin 1, it's vasoconstrictor. So what precipitates this, patients with this condition or this disease, they know the risk factors or the factors that are going to precipitate the symptoms, the bluish discoloration and the coldness and the numbness and the pain. And so all these are associated in signs and symptoms with this disease. So they will know they will try to avoid these precipitating factors like cold, emotional stress, smoking. The three significant or most common and frequently, factors that are going to result in these symptoms: cold, emotional stress, and smoking. So in the early phases, the peripheral vascular disease, in addition to these two conditions or these disorders, there is also, we have something called peripheral arterial disease, PAD, that affects the lower extremities, the arteries in the lower extremities, not the, not just the Burger's disease or the Raynaud's phenomena, but also we have something called PAD, peripheral arterial disease, can affect any artery of in the lower extremities. And that will result in a severe pain in the lower extremities as people start to walk, and they will at some point stop walking. And that is called intermittent claudication. And then they will stop walking, and then that pain will, be resolved and relieved by, when they stop, walking, and then they'll resume walking, and they will start again to feel that claudication or the pain in the lower extremities that is called PAD. So, and the manifestation associated with that is called intermittent claudication. But at early stages of the disease of the PAD, it's asymptomatic in early stages. So the case study here, it's about the atherosclerosis. I will post the answers to the case study, given that, I'll make sure that we have enough time to go over the important concepts. So arteriosclerosis, and a difference between when we see arteriosclerosis or atherosclerosis, athero or arteriosclerosis.
Isn't the atherosclerosis when there's fat in the artery, and arterial is just, I'm not too sure about the arteriosclerosis.
Yeah, arteriosclerosis, yes, exactly. The athero means there is atheroma. Atherosclerosis, there is an atheroma, atheromatous, or atheromatic atheroma, plaque. So the atheroma is the position of the plaque on the inner intima, which is the inner lining of the blood vessel. So arteriosclerosis affecting the arteries, because the atherosclerosis, it's the presence of the atheroma, which will result in arteriosclerosis. So the arteriosclerosis, the thickening and hardening of the blood vessel. It can it's due to the atherosclerosis most of the time. Would result from the atherosclerosis due to the presence of that atheromatic plaque. So the atherosclerosis, which is a form of arteriosclerosis, because that's due to the position of the atheroma and on the blood in the arteries, and will result in the narrowing of the lumen of the blood vessel. The progression of the atherosclerosis is sort of the steps or the phases in which the atheromatic or atheroma or the plaque would form from the inflammation or the inflammatory response of the endothelium of the inner lining of the blood vessel, down to the last phase, which is the complicated plaque. And that's when the blood clot will easily form on the plaque. So two things here. When there is a complicated plaque, means that there is an occlusion, an obstruction. See, how's the plaque with complicated lesion here is going to result in occlusion that will occlude part of the lumen of the blood vessel, which is an artery here. It's an artery. And if that's a coronary artery, that will be even worse, because that's, that's the artery that perfuses the myocardium. So it can affect any artery, but also it will also result in affecting the arteries that perfuse the myocardium, which is the coronary arteries. Like it's called CAD in that case, coronary artery disease. So again, two things, which would result from the atheromatic plaque or the complicated plaque that is going to obstruct part of the lumen. So it results in decreasing the lumen size, which means obstruction, and it will decrease the perfusion to the distal segment or tissues. So tissues, by passing that plaque or that obstructed site, they will be deprived of perfusion, including the oxygenation. Which is in this case would be called ischemia, ischemic changes due to the decreased perfusion. So, which statement regarding arteriosclerosis is true? Arteriosclerosis is
B.
it's a thickening and hardening of the vessel walls. Yeah. This one about the PAD. Okay. Now, CAD, coronary artery disease. The coronary artery disease, which is a changes in the coronary arteries that will decrease perfusion due to the presence of the atheromatic plaque and obstruction in the blood vessels. So I just want to go to one of the pictures to show you the coronary arteries, because we have three major coronary arteries. We have the right, the RCA, which is the right coronary artery, and we have the LAD, which is left anterior descending, and then we have the circumflex, the LMA, which is left main and left main, and then we have the circumflex, the CX. Three major coronary arteries. They all three perfuse the myocardium. Each one perfuses one section of the myocardium, but all three with the small branches of the three main coronary arteries, all the three major ones and the small ones and small branches, they perfuse the myocardium and for oxygenation and nutrients. So any occlusion in these coronary arteries or obstruction would result in ischemic changes. Complete obstruction will result in acute MI. So the patients who would be at risk for this would be hyperlipidemia, which will result in atherosclerosis. Patients with hypertension also can lead to coronary artery disease, CAD. Now there is what is called collateral circulation, which is the small tiny blood vessels that are going to perfuse the myocardium. It will be like small tiny. See, if this is the large coronary artery, there will be like small tiny blood vessels on both sides here that's going to perfuse the if there is an obstruction. The presence of this collateral circulation will be at least partially sufficient to perfuse part of the deprived, of the tissues that are deprived of the perfusion due to the obstruction of the main coronary artery. So we have a small, tiny collateral, blood vessels called collateral circulation. So that's what saves sometimes people with angina and chest pain and occlusion, or even 100% occlusion of the coronary artery. They live, with the chest pain and the angina for years, because this area distal to this, let's see that's an occlusion here. So this area is distal to the, bypassing this occlusion. This area is the segment of the myocardium that will be deprived of oxygenation and perfusion. What perfuses partially, this segment or area or tissues, that would be from collateral circulation. So the patient, but it's not enough and sufficient to to provide all the oxygenation nutrients, especially the oxygen, for the cells to to do the metabolism. So that's why the patient will have an ischemic changes, and then the ischemia will be evident or translated as chest pain. So the chest pain that's from the ischemic changes and what is called the anaerobic metabolism, the metabolism with the absence of oxygenation or oxygen. So just to remember that collateral circulation, that's what saves the the patients, and that they can live with chest pain and angina, and there is some perfusion. Otherwise, if there's complete obstruction and there is no perfusion, that will result in complete death for these cells and necrosis and necrotic tissues, and that will be acute. We call this acute MI. But over the years, I don't think these cells will ever can live with no perfusion. So that's why there is collateral circulation. Just remember that collateral circulation is present and both in the corner and it's present. Across the vascular system, but mostly it will be significant in the brain and the heart. So in the brain, the same concept will apply also for the patients with the brain attack or CVA, and you can apply the same concept for collateral circulation in the acute MI or patients with cardiac insufficiency or cardiac ischemia. So the CAD, these are the risk factors on that table. Providing, the table provides the within range and out of range values for total cholesterol, LDL, triglycerides, and HDL. So risk factors for coronary artery disease. What would you include under the risk factors for CAD?
Smoking, drinking, high cholesterol.
Yeah, right. The presentation did include some of these risk factors. Right. So family history also. Age. This is unmodifiable risk factors. Genetic predisposition, ethnicity, gender, age. These are unmodifiable. But we have also modifiable risk factors. Right? So the modifiable risk factors, the major ones, as stated, hypertension, smoking, diabetes, obesity, physical inactivity. You can also mention in the presentation about the substance abuse, elevated blood, hyperlipidemia, or the elevated serum lipids, metabolic syndrome. There is also a kind of recent studies. They are studying or assessing the correlation between the cardiac events and CAD and the homocysteine levels. They found that patients, who had the higher levels of homocysteine, they tend to develop a, CAD and cardiac events or cardiac problems, especially acute MI. Because the homocysteine, it's, revealed, the studies reveal that the homocysteine will damage the inner lining of the blood vessels, and it will promote the plaque buildup of the atheroma or the plaque formation, and other changes as well. So the dyslipidemia, hypertension, cigarette smoking, diabetes, obesity, lifestyle, sedentary lifestyle, all of these are modifiable, that we can work on, and modify these factors and prevent the CAD. So these are the numbers for, or the values for the within range, and it's listed as as desirable, low, borderline, high, very high. So let's take these numbers. For example, the total cholesterol supposed to be less than 200. LDL optimal less than 100. Triglyceride should be less than 150. The HDL, it says here low as less than 40, but we attempt to maintain it above 40. Other textbooks would say 50. So above 40 or above 50. That's the the objective is to maintain it above that number. So the CAD, coronary artery disease, we mentioned about the risk factors, both modifiable and non-modifiable. Now, myocardial ischemia, it's different than acute MI. Acute MI, when there is a complete blockage, 100% blockage of the blood vessel, that result in acute MI. But patients with myocardial ischemia, which is called angina or angina pectoris, they can live with this, for months, years. I've seen patients who refuse to do the open heart surgery and lived with ischemic changes with angina with 15, 20, 30, even 35 years. And but they have to be careful with the physical activity, and physical exertion, with the emotional, also, the emotional stressors. They have to be also careful with the treatment of the angina, in terms of that. When anytime patient will have a chest pain, they have to stop the activity and they have to take the nitroglycerin, because that's to perfuse and to stop the progression of the ischemic changes or ischemic events and increase the perfusion to the myocardium. So the ischemic changes or myocardial ischemia is the angina. But we have different types of angina. Could be stable, unstable, and transmittal angina. And there are even more than these types of angina. But these are the most common ones: stable, unstable, and transmittal angina, and silent ischemia. The difference between stable angina and unstable angina is that the stable angina is usually relieved by or when the patient takes the nitroglycerin sublingual, because nitroglycerin comes in different formulations, comes in sublingual tablets, small tiny sublingual tablets under the tongue, comes in also tablets, comes in IV, patches, transdermal patch. But the sublingual one, that is 0.2 or 0.4 milligrams, that will be taken under the tongue. So these patients, they know that you have this little tiny bottle in their pocket, and they're always, they will have this, drug with on their possession with them whenever they go. So anytime they feel or experience that chest pain, they know this is anginal pain, and they will take the first tablet. 5 minutes, pain persists, chest pain still there, they will take the second one. And then 5 minutes, they will wait, and pain hasn't been relieved, they will take the third one. After the third one, which is 5 minutes apart, 15 minutes, they have to call 911. Because after 15 minutes, this is unstable angina. If the pain still persists, but hasn't relieved, after 15 minutes, after the third sublingual nitroglycerin, that is unstable angina or acute MI. That's why there is a no designation or no category or classification of the cardiac events. Now, the unstable angina is categorized with the acute myocardial infarction, both of them will, are listed under what is called the ACS, acute coronary syndromes. Acute coronary syndrome, ACS, it includes the, and I believe that that when you watch the video, you'll find, these classifications. The, Perlin and Tiffany, presented. I saw that, some of these, the part of the video talks about the classification of acute coronary syndrome, and listed under that both the unstable angina and the acute myocardial infarction. So the stable angina, the difference between the stable, and that's why stable angina is not listed under the acute coronary syndrome, because stable angina means that the patient will experience chest pain. Let's say they are, mowing the lawn, or they are doing like, they are doing any type of activity, physical activity, and they are, then, or even sometimes just walking, ambulation by itself, it can be like in a physical exertion and can result in chest pain. So any activity, that patient experienced a chest pain in response to any physical activity, and patient will stop that activity, pain resolved, or pain is kind of, relieved, then this is a stable angina. Patient stopped the activity, patient took the sublingual, tablet, nitroglycerin, and angina, chest pain stopped. That is a stable angina. So stable angina is different than unstable. Unstable will still persist even after. First of all, the unstable angina will, patient will experience chest pain without any physical activity. So it's not associated with any physical activity or physical exertion. But stable angina is always linked to, or comes in response to, that physical exertion. Any questions so far? So under the acute coronary syndrome, we will have unstable angina and the acute myocardial infarction. In the acute MI, we have two different types. We have STEMI and non-STEMI, and I will go to that in a minute, or in a few minutes. The difference between the STEMI and the non-STEMI acute MI. First of all, what is the significance of the EKG? Because anytime, when you go to the telemetry, or, tele floors, or cardiac floors, or post-op, post open heart surgery floors, they always look at the EKG and try to associate changes in the myocardium with the EKG. Does anyone have any idea why EKG is so important in these floors? And
because it will allow us to see the heart, if there is any abnormality in the heart, and especially if there is any AFib or PAC, or any atrial flutter, any abnormality in the heart, and it will be helpful to detect any myocardial infarction at the same time.
Yeah, so the changes in the myocardium will be reflected in the EKG or in ECG. ECG or EKG can reflect the changes in the myocardium. If there's an ischemic changes in the myocardium, it will be reflected in specific changes in the EKG. If there is necrosis, also will be reflected. So let's take a look at this. This is a patient who had sustained a acute MI, and it will. So these are the changes, or the change pattern of the EKG in the affected leads. It says here that the patient will have acute. So the ischemic changes will be reflected as an ST elevation. So this is an ST elevation, ST segment elevation. So we have a PQRST. So this is an ST elevation. You'll find that the patient will have, if there is a necrosis, necrotic changes, the death of the cells, and that is permanent. This is reversible. Once the patient has the ischemia is being relieved or resolved, then the ST elevation will disappear, and this goes back to normal. This one is Q wave. This is a Q wave. This is depressed Q wave. This is small. This is depressed Q wave. So this is what is called pathologic Q wave. Q wave, in addition to the T wave inversion. But mostly we can just take a look at the Q wave here as the pathologic Q wave abnormal, and that is consistent with necrosis and necrotic changes and the death of the cells. That's why it's irreversible. This Q wave will stay forever. Patient who had developed acute MI and they have a Q wave, that is irreversible. That will never go back to normal. And then later on, the ST elevation will be normalized, will go away. And so we have a T wave inversion, ST elevation, and Q wave. Three things, at least, we have three changes in the EKG that can, correspond to changes in the myocardium and will give us some indication of what's going on in the myocardium. If there is an ischemic changes, there is necrosis. So last session or lecture, I asked a question about when the coronary arteries or the myocardium gets the perfusion, receives the blood or perfusion through the coronary arteries. And this picture explains very well that the coronary arteries will, be open during the diastole. So the perfusion to the myocardium will take place during the diastole, not the systole phase of the cardiac cycle. So this another chart that shows flow chart shows the acute coronary syndromes, the ACS. So myocardial ischemia due to the decrease in oxygenation to the myocardium, and that's from the obstruction in the coronary arteries, the RCA or LAD, left anterior descending, or the circumflex, or the left main, or the right coronary artery. Any occlusion in these main, large arteries, which perfuses the myocardium, any occlusion, blood clot, or atheroma, large atheroma, atheroma, obstructing the artery, that would result in decreased perfusion, and that will decrease oxygenation, and then the ischemia and ischemic changes will develop, and patient will experience that chest pain. Total occlusion will result in anaerobic metabolism and lactic acid accumulation, and that's the source of pain patient experiencing that chest pain due to that lactic acid, acid accumulation from the anaerobic metabolism. So each one of these coronary arteries perfuses one segment or one section of the myocardium, RCA, LAD, circumflex. The circumflex goes posteriorly. That's why you see part of it, and then it goes to the back of the the myocardium. That's why that's the that circumflex. But the LAD, that's anterior, left anterior descending. So these are the three major ones. Plus, as I said, we have also small branches, comes out of each of the three main arteries. But these are the main coronary arteries that perfuses the myocardium. So any obstruction will result in decreased perfusion distal. So if there's an obstruction right here in the LAD, then this area will be deprived of perfusion and oxygenation. And then that's would result in ischemic changes, ischemia, and may it last longer, then result in necrosis. The healing process. The first 6 hours is very critical after the acute MI. because the physical changes do not occur in the heart until 6 hours after the infarction, which means, or this explains the need for the intervention within the first 4 to 6 hours of symptom onset. So once the patient started, began to experience that chest pain, and that's confirmed to be an acute MI, then treatment has to be started, which in this case would be the best treatment would be to dissolve and to degrade this blood clot with a medication called TPA, anti-thrombolytic drug that's going to dissolve the blood clot. So the complications from the acute MI, before we get to the complications, the healing process, the myocardium will become weak from that necrosis, ischemia, necrotic tissue, necrosis, so that part of the myocardium will be weak. So that will affect the cardiac output because there is scar tissue, result in decreased contractility, will be more stiff, less contractile, and less output. So that significantly will affect the cardiac output. So the complications, before we get into complications, just go briefly over the stable and unstable angina. Make sure that we spend some time to differentiate between, the transmittal, especially I did not, explain the transmittal angina. The transmittal angina, which is what is called variant angina. And variant angina or transmittal angina results from the spasm of the coronary artery. Spasm that occur in the coronary artery, and patient will, experience the chest pain and the ST elevation of the ST segment. And the unstable, we said that the unstable, that's usually it's no onset. So it's not consistent, like every time it will be the same type of pain or chest pain. Usually it's no onset, because patients with stable angina, they will experience the same type of pain, of chest pain, every time they will experience that. I mean, they perform that specific, like let's say like physical activity or physical exertion or emotional, stress, experience. They will anticipate that chest pain that will be the same all the time. But with the unstable angina, the angina, it's no onset. It occurs at rest without any activity. It's not associated with any activity. And the pattern of the pain, it's worse than patients with stable angina. And it's very unpredictable. They cannot anticipate like this type of angina when it's unstable. They cannot, there is no way they can associate this type of anginal pain with any factor. But with stable angina, they know, if I'm going to do this type of activity, I'm going to experience, pain, chest pain, but I will stop, that specific activity, and I would take the sublingual nitroglycerin. But unstable angina is different than this. And that's why we consider unstable angina as the one type of the acute coronary syndrome, ACS. So acute MI complications, we have something called Dressler syndrome. And the pulmonary embolism. And the Dressler syndrome, which is a combination of antigen-antibody reaction and inflammatory changes. And the patient will experience the chest pain, will experience also fever from the inflammatory response, arthralgia, which is joint pain, and the lab values will reveal an elevated white blood cells and ESR, which is erythrocyte sedimentation rate. ESR, erythrocyte sedimentation rate will be elevated. White blood cells will be elevated as well. That's called the Dressler syndrome or post-MI syndrome. Another name for that is a post-MI syndrome. So diagnostic studies for the acute MI, we will focus here on the serum cardiac enzymes. These enzymes will be released or elevated in the blood in response to the acute MI. So you will hear about this in the clinical. You haven't heard, by now about the troponin. You will always, hear nurses and practitioners and physicians talk about troponin levels in post, patients with acute MI or suspected acute MI. And the ER, once the patient having let's say like a chest pain and they suspect acute MI, they will, right away they will do draw blood level for cardiac enzymes. So the cardiac enzymes, which in other words, that the enzymes are going to be released from the myocardium in response to the ischemic changes or the acute MI. We have three main or different types of enzymes: creatinine kinase, troponin, myoglobin. CK, or we have specific type of CK, which is specific to the myocardium, called CK, and then you can put a slash and then MB. CKMB, because you have other types of CK like BB and CKMM, but CKMB is specific to the myocardium, CKMB. It will be elevated in addition to the troponins and myoglobin, but the most, the one that is specific and sensitive to the myocardium, and it's more diagnostic and more, we can rely more on it for diagnosis, is the troponin. And we will go into more detailed explanation why and the different types of troponins. We have two different types of troponins, and that will be in adult health too. So just for now to know that the enzymes are CKMB, troponins, and myoglobin, and the most important one that is going to determine the acute MI will be troponins, and more specific and more sensitive to the myocardium, which is the troponin. Okay, so let's go over the case study. Any volunteers to read out loud the case study?
I can read.
Please, thank you.
Sorry. Donia, I don't know. Dunia is 56 years old, smokes half a pack of cigarettes a day, and is overweight. Her friend wants her to come to a local women's fitness class she attends once a week. She knows Deborah's dad had died from an acute MI when he was 56, and she fears seeing Deborah's lifestyle. The same fate awaits her friend. What she didn't know was that Deborah had also been to her doctor for her annual physical, where she was told her LDL levels is 180, HCl is 36, and cholesterol is 239. Lists Dunia, or I don't know her name, Dunia's known risk factors for coronary heart disease. She's
So
smoking.
let's highlight the or underline, the risk factors for Dunia's scenario. So yeah, you said 55, right? 55.
It's her
Yeah.
age.
56. So
Her
age, yeah.
She has family history of her dad.
Family history of heart disease.
Mm-hmm.
High HDL.
Did you mention smoking too, right?
Yeah, smoking. She has high cholesterol. She's
The
overweight.
Overweight.
Yeah.
What else?
Physical inactivity.
Good.
Let me see.
High LDL.
Yes, good.
Low HDL.
Yeah, so you said low HDL and then high LDL, right?
Yeah.
High LDL and low HDL, because we want that happy lipoprotein, the HDL, we need it to be high, right? The happy one should be high, higher than 40 or 50. So yeah, so these are the risk factors. Perfect, yes. Number 2, who wants to take number 2? Second question.
I'll read it.
Go ahead.
Donia's doctor referred her to a dietitian for strict dietary therapy, hoping the intervention would raise her HDL and lower her LDL and cholesterol levels. Explain why diet modification is necessary to control and moderate the lipids indicated.
Which, yeah, go ahead.
I want to say because of the current level she's at risk for like clogged arteries and everything.
Yeah, so it's there's the risk factor here is the excessive caloric intake, the calorie intake, it will lower the HDL levels. High calories is going to lower the HDL, and we want the HDL to be higher than 40 or 50. The elevated serum cholesterol are affected not only by dietary intake of cholesterol, but also by the diet high in saturated fat. So we should be, we have to be careful with the, food that is high in saturated fat. So the trans fats also, there's something called trans fats. That's also we have to be careful with, trans fats, because trans fats, just on a side note, will be high in fried food, will be high in like, bakery stuff that stays on the shelves for a while, long standing, bakery stuff, or like, food that will have over time, that will increase, that trans fats will, be increased over time. The more or the longer the, these bakery kind of, food is going to be shelved or on the shelf or be stored. In addition to that, the frequent use of the same oil, that's result in more trans fat. Number 3,
I'll read it.
Thank you.
Donia's doctor also gave her pamphlets describing strategies to stop smoking and a list of exercise ideas she might want to try. How is smoking thought to contribute to atherosclerotic plaque formation? Why would exercise have a positive effect on Deborah's lipid profile? I would say smoking contributes to the oxidative process and damages the endothelium,
Mm-hmm.
And what else? So exercise, what to say about exercise? So exercise will reduce our lipid, our fat, our total fat.
Yeah, right, exactly. The smoking, yeah, is thought, you know, to contribute to the oxidative processes in the blood vessels, and consequently damages the endothelium. Right. The exercise, it increases the serum HDL. It will elevate the HDL, and we know that the high levels of the HDL, they are inversely related to the development of the CAD. So the higher levels of HDL, the lower the incidence or the likelihood that patient will develop the coronary artery disease. Number 4.
Atherosclerosis is thought to be an inflammatory disorder. Outline the role of macrophages in the formation of atherosclerotic plaques. What is the significance of elevated serum CRP levels in at-risk individuals? So I know that the CRP levels is like an indication marker that tells us that the patient's heart is inflamed, so it's kind of working harder than it has to. So we know there's probably going to be like a pathological issue.
Right, right, yes, and we did not go into, you know, lots of details about, you know, this specific process about the macrophages and how the monocytes migrate to the subendothelial space in the blood vessels, but the monocytes will migrate to the subendothelial space in the blood vessels and then become macrophages. Now, the elevated CRP or levels of CRP, it's always associated with the inflammatory response. It will indicate systemic inflammation.
Is that for any like any organ, or is it just for the heart?
Any
Like
inflammation, yes, any inflammation.
okay.
That's why the CRP is not, it doesn't confirm or rule out any disease. It just will indicate that there is an inflammatory response or inflammatory process in the system or in the body.
Okay, so then the troponin levels would be the most like accurate then, right?
I'm sorry?
The troponin levels would be the most
Oh,
accurate.
yes, yes. These enzymes are specific and sensitive to the myocardium. Yes.
Okay.
Yeah, yeah. So another case study.
Dr. Mickey, I have
Yes.
a question.
Yes.
The troponin, it would be more likely as a marker to detect a myocardial infarction, right? Like if someone had recent a heart attack, the troponin it will be there up to 7 days.
Well, there is, yeah, we'll go over the, you know, the specific times in terms of each, for each, you know, these enzymes, how long it stays in the blood and how long, because there is a 3 different time frames. When the enzyme will start to rise in the blood, and then when and how long it will stay, and then will go back to normal. Right? So for the CK, and for the heart, we always use the CKMB. So the levels will rise in like 3 to 12 hours after the acute MI, and then it will peak in about 24 hours and goes back to normal in 2 to 3 days. It will go back to normal. However, the troponins, we have 2 different types of troponins. They will start to peak in about 3 up to 12 hours from the onset of the acute MI, but will peak in about 24 to 48 hours, and it goes back to normal in longer than CKMB or even the myoglobin, because it will take, it depends on that troponin 1 or T. 1, it will take about 7 days, and the T about 2 weeks, 10 to 14 days to go back to normal. But the myoglobin, which is not specific to the myocardium, it can affect any muscle, but still but it will be also elevated. That's why we don't rely much on these, on CKMB or on myoglobin. We always, go with the troponins. So myoglobin, it will, will elevate in the blood within few hours after the acute MI, and it will peak and about there is no peak for specific peak for that, but it will go back to normal within 24 hours. The first one to go up, and then the first one to go back to normal is the myoglobin. So anyway, so we don't stress. I mean, we didn't focus much on the CKMB or myoglobin. We always zero in and stress much on the troponins, because that's sensitive, specific to the myocardium, and it will even stay in the blood longer than the other enzymes. Yeah. So anytime you hear cardiac enzymes, I mean, most hospitals, they have different protocols, but all of them across the board, they will go with the troponins, either one or T. Did I answer your question, Pasio?
Yes.
All right, so the next case study, volunteers for.
A nurse is caring
I can read.
Thank you.
A nurse is caring for a 35-year-old man in an outpatient clinic. The patient has been diagnosed with both hypertension and hyperlipidemia. He is currently taking medications for both. Today, he is seen in the clinic for a patient education meeting. His blood pressure today is 150/100. Number 1, the patient was given his laboratory results on his last visit and asked the nurse to explain the importance of the following results. So total cholesterol 250, HDL 50, LDL 130, triglycerides 250. So his LDL and triglycerides are too high. So those are risk factors for coronary artery disease.
Okay. So number 1, yeah. So number 1, the HDL cholesterol is considered to be protective against atherosclerosis. So the HDL is 50, which is good or bad? 50.
Good.
That's
Okay.
bad.
HDL 50.
The
Good.
HDL is fine.
It should be greater.
Is in the
right?
range 50 and over.
Should be greater.
Greater than 50. Yeah, they go with, like not 50, but greater than 50.
Okay.
Yeah, because that table, I think, explains the optimal, the optimal and the desired, and the numbers to be over. So what about the total cholesterol 250?
That's high.
Yeah, it should be less than 200. And the LDL is 130, and it should be
Less than 100.
less than 100. And triglycerides 250, and it should be
Less than 150.
yes. Number 2. Sorry. What history should the nurse obtain to determine the patient's risk factor for elevated lipids?
So he has hypertension, so maybe like his vital signs or like family history, his diet, what is he eating, his lifestyle, is he drinking, smoking, substance abuse, stuff like that.
Yes, exactly. So gender, family, history are, the non-modifiable risk factors, but also we have an age is a risk factor for elevated lipids. So yeah, what you mentioned is absolutely correct. But what about the modifiable risk factors? Smoking, right? As I said, presence, or if the patient has hypertension or diabetes, overweight or obesity. So the nurse needs to take into consideration the history that identify any of these risk factors, so they can work on or develop a plan to change these factors, or to modify these factors based on the plan of patient education. Number 3.
Using current guidelines for classification of blood pressure, what stage does this patient fit into? It will be stage 2.
Yeah, blood pressure is 150 or 100, right? So that, patient will be stage 2 hypertension. And number 4.
What history should a nurse obtain to determine the patient's risk for elevated blood pressure?
Which, yeah,
Um,
modifiable versus non-modifiable factors for high blood pressure. Non-modifiable risk factors, which include blood pressure.
Family history.
Family history.
Right. Family history, gender, race, age. Modifiable risk factors include blood pressure, high blood pressure.
His diet and
Diet, especially the high calorie diet,
Sodium.
high sodium, yes, high sodium intake, high lipid. In addition to also, weight, obesity, and physical inactivity or decreased physical activity, alcohol intake. All of these are modifiable risk factors. Okay, and then number 5.
Number 5 is pretty much going to be the same answer that we said, like the modifiable lifestyle changes, like the patient needs to exercise more, maybe understand like the impacts that having high blood pressure and the hyperlipidemia has on him, because he's so young still. So at the rate that he's going, you kind of have to like reverse it a little bit, because
Right. So we will identify these 6 factors and work on one of each, the list of these factors, and try to plan or develop like, an effective plan to modify these 6 factors for like, to stop smoking, or to decrease calorie intake, to increase physical activity, moderation of alcohol and salt. So these are, going under each one of these elements. We will develop a plan so we can modify the risk factors. Next, the last case study. So I believe we have 10, what is that, 5 minutes? So yeah, just I don't think we'll be able to do the case study and the questions in about 5 minutes. So I can post the answers on Blackboard. Sharing.